Welcome to our webinar, Normal Tension Glaucoma, What You Need to Know. My name is Brizette Castellanos, and I am the Manager of Outreach and Social Media at Glaucoma Research Foundation. Joining us today is Dr. Ruth Williams. Dr. Williams is a glaucoma specialist at the Wheaton Eye Clinic in Illinois and serves on GRF's Board of Directors as Vice Chair. After attending Rush Medical College in Chicago, Dr. Williams completed an ophthalmology residency at California Pacific Medical Center in San Francisco and a glaucoma fellowship at Schaefer Associates and the University of California, San Francisco. She is a past president of the American Academy of Ophthalmology, and before serving on the Academy's Board of Trustees, she represented ophthalmology at the American Medical Association for nearly a decade. She has served on the board of several other ophthalmic organizations, such as the American Glaucoma Society and Women in Ophthalmology. After Dr. Williams' presentation, we will be joined by a glaucoma patient for the Q&A portion of the program. Hillary Golden has over 20 years of experience in medical sales and training, in addition to being a certified health coach. Diagnosed with severe normal tension glaucoma in 2020, she has extensively researched the disease, leading her to work in surgical glaucoma device sales and training. Hillary has become a patient advocate and public speaker and has spoken at fundraisers, research meetings, and webinars. She founded Glaucoma Coach, where she works as a sales and marketing consultant, a one-on-one coach for glaucoma patients, and is a keynote speaker. Please welcome Dr. Williams.
Thank you, Brizette. I'm so happy to be here with you today. I love taking care of normal tension glaucoma patients, and as you'll hear from my talk today, it's a subset of glaucoma patients that have particular findings often and different intraocular pressure targets often. One of the things I love most about being glaucoma specialist are all the different people I get to know. I may go into one room with an elderly man who has had a blood clot in one eye and is blind in that eye and then has high pressure in the other eye. Or a patient I saw just a couple days ago, a young woman who's a beautician and working mom with 3 little kids and glaucoma issues. And while the diseases have so much diversity and the patients do too, there's one thing that is common to most glaucoma patients, and that is they're afraid. And one of the ways I think that one of the best ways to combat fear is with information. And that's why I love these Glaucoma Research Foundation webinars, is it gives us, the clinicians, a chance to share with you information about glaucoma. I'm going to ask the first question or answer the first question. Well, really, what is glaucoma? And it's not one thing. It's a collection of diseases that have different causes, but have some things in common. And traditionally, for most kinds of glaucoma, what we say have in common is very patterned damage to the optic nerve that often looks like this visual field, which we call a superior arcuate scotoma. So it's that rainbow-shaped darkness that can develop in the superior visual field or the inferior. And that these classic changes are associated with, presumably caused by, elevated intraocular pressure. But there's a subset of patients who have these typical changes, and yet the intraocular pressure is not high. And in that case, we call it normal tension glaucoma. So normal tension glaucoma are the traditional optic nerve abnormalities, visual field defects, optic nerve scanning thinning, but the intraocular pressures are not normal. We also, just to make things confusing, have a lot of different names for it. Some people call this low pressure or low tension glaucoma. I personally prefer to call it normal pressure because the pressures aren't really low, they're just in the normal range. And in our treatment, we also often want to get the pressures very low, but at diagnosis, typically the pressures are in the normal range. And then also, just to make things interesting, sometimes patients who have what's called normal tension glaucoma for a long period of time, maybe years and years and years, will come in and all of a sudden have high pressure. And so there can be a range of disease that is on a continuum that includes normal tension glaucoma and primary open angle glaucoma with high pressure. And then the last thing is something that I often write in the chart is primary open angle glaucoma with features of normal tension. So as you'll hear from my talk, normal tension glaucoma has some features that tend to be more common. And those can be in the normal tension patients, but they can also show up in patients with elevated pressure. And so I'm going to talk about some of these features, which include a discussion of intraocular pressure, which is way more interesting than you might think, risk factors for low pressure or normal tension glaucoma, and some of the typical clinical features. And all of these things are not necessarily present in patients with normal tension and can be present in patients with high pressure glaucoma, but they tend to be more common in normal tension patients. So this is a photograph of a patient getting her eye pressure checked. And all of you who have glaucoma are familiar with what we call Goldman applanation tonometry. And you see that that tip touches the eye, and we measure the amount of pressure it takes to flatten out the cornea. But I want to show you what I see when I'm checking your pressure. And here is what I see. I see these two rings, and we measure the pressure by turning a dial until those rings just barely touch but don't overlap. In this picture, they're actually overlapping a little bit, but that's my view. So we're going to talk about pressure in patients with glaucoma that we call normal tension, and typically the pressure is in the normal range. But what's fascinating about pressure is that we only get a few pressure checks a year. If your glaucoma specialist is following you really closely, he or she might have more, but really we only have a few data points. And it really doesn't tell us anything about what's going on when you're not in the office, you know, the next day, the next hour, or most interestingly, actually in the middle of the night, which I'm going to talk about. So intraocular pressure can sometimes fluctuate and we can miss the higher pressure. And we also know that fluctuation itself is a risk factor for progression, for getting worse. So some patients always have the same pressure, and some of you have pressures that are different at different times, and that itself can be a risk. And the intraocular pressures tend to be highest in the early morning hours. So we don't have the opportunity to check your eye pressure at, say, 4 o'clock in the morning typically. And that can be when progression or getting worse is happening. We do know and have a very good evidence base that with patients with normal pressures, that lowering the intraocular pressure, even though they're not high, lowering the intraocular pressure decreases the chance that the glaucoma will get worse. So lowering intraocular pressure is still the mainstay of treatment. Interestingly, Glaucoma Research Foundation was central to this knowledge. When I was doing my glaucoma fellowship over 30 years ago, we actually didn't yet know. And indeed, that study showed that lowering pressure helps stop progression. And that study that was done then, along with one other, are the studies that are still quoted to this day about how to treat normal tension glaucoma. I'm going to show you a couple visual fields that are very interesting, but this is the visual field of one of my patients, a 57-year-old woman whose glaucoma was getting worse in one eye. And I want to show you her visual field, which had what we call pericentral scotomas, or a blind spot very near the center. These are serious defects and more common in normal tension patients because they're in the central vision. And if it gets worse, you can lose vision in the center, which affects quality of life more aggressively than a more peripheral blind spot. And my patient had pressures of 10 every time I saw her. So she was getting worse despite intraocular pressures that seemed to always be well controlled. And so the question was, what's going on? Is the pressure spiking when she's not here? Or is this a kind of glaucoma that's getting worse even with low pressure? And so I had her check her pressures at home. And what we discovered is that her intraocular pressures were spiking up to 17, which for this patient was a high pressure because her pressures were about 17 when she was first diagnosed. Her pressures were spiking up, look at the time, at 4:20 a.m. and at 5:48 a.m. an hour I am not in the office to check intraocular pressures. And you'll see that her pressures also were as low as 6 and 7. And so we identified that she was spiking up at 17 and needed a procedure to lower her intraocular pressures. And here's another depiction of those pressure spikes. This is a different data point, but this one, it was 4:20 a.m. and another one at 4:20 a.m. in the other eye when the pressure was actually spiking up to 14. Patients who have high pressures at 2 o'clock, 4 o'clock, 6 o'clock in the morning, these are occurring when the blood pressure is the lowest. And that is when much of the glaucoma can be progressing. So low diastolic blood pressure is a common association with normal tension glaucoma. Diastolic is that bottom number. So there's the top number and the bottom number of the blood pressure. And when the bottom number is too low, it can cause progression of the glaucoma. And I just want to emphasize the mainstay of treatment for normal tension glaucoma is getting the pressure down. And in some patients with that, we want your pressure around 8, 9, or 10, or 11 or 12. But typically, we want you in the single digits or around 10 for many of the patients. I'm now going to talk about normal tension glaucoma risk factors. So these are the things that make me more curious about your glaucoma or thinking that you may have low pressure glaucoma. So we've already talked about how intraocular pressure is still the major factor in this disease. Another risk factor, just as with high pressure glaucoma, is a thin cornea. And while if you look at the data, the normal tension glaucoma patients tend to be older than primary open-angle glaucoma patients. There's a subset of people who are young and tend to be women. So I have a whole practice of young women with normal tension glaucoma, even though on average they tend to be older. Japanese ancestry is also a risk for normal tension glaucoma. In one large study of glaucoma patients of Japanese ancestry, 92% of them had normal tension. Sleep apnea can also be associated with normal tension glaucoma. It also can be associated with high pressure glaucoma. But the ones I find most interesting are the vascular risk factors. So it's very, very common for a normal tension glaucoma patient to have what we call vascular dysregulation. And what we mean by that is other vascular issues that don't work perfectly. So for example, it's common for patients to have associated migraines. The other one that I already mentioned is low diastolic blood pressure. So I will ask my patients, I take a very, very careful blood pressure history. I'll say, do you ever get lightheaded? And that can sometimes be a sign of overtreated high blood pressure. So I will ask, I say, do you have low pressure? Oh, no, I have high blood pressure. And I'll say, but what's your blood pressure on treatment? And sometimes our normal tension patients will have very low diastolic blood pressures, because to get that top number down into a range that decreases your risk of stroke or heart attack, the medicines that bring the top number down also bring the bottom number down, and sometimes too low for your optic nerve perfusion. Some of my normal tension glaucoma patients are cold people. So I'll say, are you one of those people that has to put a down sweater on when everyone else is comfortable in the room? It's common. And then the last one that I ask about is Raynaud's syndrome, because the blood vessels are inappropriately constricting. And I'm going to show you another picture of Raynaud's, because this is a picture of my hand. It's probably a subset of low pressure glaucoma patients that have these vascular dysregulation findings. And then I'm going to talk a little bit about the clinical features. But before I do this, I just want to make an editorial comment about the beauty of the eye. This, again, is what I see when I look in the slit lamp at an eye. And it's not just a brown iris. It's a brown iris that has clefts and valleys. Another eye might have freckles and different colors of the iris. And so every one of us has a unique eye, and every person with glaucoma has a unique case of glaucoma. So in our normal tension patients, they're on a continuum with high pressure glaucoma patients, and the angle is open. It's very common to have a thin cornea, but not all patients have a thin cornea. Again, it's very common to have certain kind of visual field defects, which are more localized, and I'll show you a couple. It's also very common to have hemorrhages of the optic nerve, which can also happen in high pressure glaucoma, but is more common in normal tension patients. I'm going to show you a picture here of an optic nerve. This is a picture. You can see that white part in the center is the lumen through which the blood vessels flow back and forth to the brain. And then that kind of peachy colored rim is the neuroretinal rim that is your optic nerve tissue. And if you look at this particular picture, you can see that there's a focal little notch at the bottom. And that is more common than the diffuse loss that we can see with other kinds of glaucoma, although you can have either kind. And if you look up at 12 o'clock at this picture, you'll see that feathery hemorrhage, also more common in patients with normal tension glaucoma. Now, I'd never miss, actually, no ophthalmologist would ever miss a big hemorrhage like that. But more typically, we see these little feathery hemorrhages, maybe even smaller than this one. And those are very common in our normal tension patients. And while they are not always associated with progression or getting worse, it's more common to find, after you've had a hemorrhage like this, a little thinning of the optic nerve tissue or the OCT after a hemorrhage in that area. So it can often be a sign for us that the glaucoma is getting worse and requires more aggressive treatment, or at least thinking about more aggressive treatment. This is a typical visual field that many of you have had, and a typical visual field measures out about 24 to 30 degrees of vision, so a good chunk of vision. And a very common visual field defect in high pressure glaucoma is this, what we call superior arcuate scotoma, or that rainbow shaped defect. However, in our normal tension glaucoma patients, it's very common, as I already mentioned, for the scotoma to hug the center. And I'm always very, very concerned about these hugging the center visual field. So while a visual field called a 24-2 goes out 24 degrees of vision and checks a point every 6 degrees, in my glaucoma, in my normal tension patients, you're lucky, the lucky patients that get more visual fields, at least for me, because I'll also do what's called a 10-2, which just looks at the central 10 degrees of vision, but checks a point, a data point every 1.5 degrees. So it's a much more meticulous map of that central visual field defect. And you can see in this one how there's a little island of normal vision in the very center here, and we would work very hard to protect that little central area where the vision is actually still normal. And here's another picture, classic kind of defect. I call these hook defects, and they're very, very typical of our normal tension patients. The mainstay of treatment is to lower intraocular pressure, and we use all the traditional ways of doing so, which include drops, laser. I love laser even for normal tension glaucoma. Injectable, there's an injectable pellet that elutes medicine inside the eye. Cataract surgery combined with something we call MIGS, minimally invasive glaucoma surgery, which is very, very, very common, but it's more common in low pressure glaucoma patients to require surgery, such as a trabeculectomy. And the reason is that the trabeculectomy is it's the best way to get the pressures very low if you need a pressure of 8, 9, or 10. And so we might be more inclined to recommend surgery in normal tension patients than we might in another patient, or this kind of surgery is what I mean. The most important part of caring for patients with normal tension glaucoma is to follow them carefully. I may see my normal tension patients more frequently, especially if they need a 24-2 visual field and a 10-2, and I want those done enough time so I can really plot progression over time. And we may do OCT twice a year instead of once a year. So the normal tension glaucoma patients are probably often seen more frequently and tested more carefully. But the beauty is that we're very, very good at measuring the progression and halting it and giving our patients a wonderful, often very normal quality of life. And I'm showing this last slide because it illustrates something that I think is the most important thing about my job. This actually is a picture of my almost 93-year-old mother who has vision loss, and she's not able to drive, but she was able to get on a plane and fly to Denver to go to my son's graduation. And when I look at that picture, it reminds me of all of my patients with vision loss who were able to keep enough vision for them that they can have a wonderful quality of life. And that is why I love my job. It's not about doing visual fields all the time on my patients. It's not even about lowering the pressure. It's about maintaining quality of life for my patients and for providing hope. And that's why your glaucoma specialist shows up to work. And that's why he or she does her job. And it is really the most meaningful thing in the world. And I'm so glad to have Hillary Golden on this call or on the Zoom, because she represents a patient who brings hope to our community of glaucoma patients. Thank you so much.
Thank you, Ruth. That was amazing. Thank you to everyone who submitted questions, and thank you to our panelist, Hillary, for joining us. Hillary, can you please start us off by introducing yourself and telling us a little bit about your journey with glaucoma?
Thanks, Brizette, and thank you, Dr. Williams. That was a great presentation. So in July of 2020, I was diagnosed with severe normal tension glaucoma. I had a sty, and I scheduled an appointment with an OD to get it checked out. When she did the full eye exam and my eyes were dilated, she looked inside and she said, "I don't like the look of your nerve." And I said, "Well, I don't know if you know why I'm here, but I'm here about this sty, so that's really my main concern today." And she said, "Well, my main concern is your optic nerve." So she started out doing a confrontational visual field test where she had me cover one eye. And she said, "How many fingers am I holding up?" And I said, "I can't see your hand." And she said, "Well, we're going to do a couple more tests." So we did an OCT and a visual field. And when my visual field came back, showed that I had lost almost 40% of my sight at that point. So she sent me immediately to a glaucoma specialist who put me on drops and confirmed that I did in fact have glaucoma. So the two things that I thought I knew about glaucoma at that point were were simply incorrect. So the first thing I thought was that you had to have high pressure to have glaucoma. My eye pressure was 13 and 14 at diagnosis. I also thought you had to be in your 70s or older to have glaucoma. And so both things that I knew, and I found out you could be any age and have glaucoma. So both things I knew were absolutely incorrect. So I needed to learn more about this. Additionally, 6 years before I was diagnosed, I had been to 3 different ophthalmologists, and none of the ophthalmologists found my glaucoma. Unfortunately, this is common with normal tension glaucoma, and most patients are not diagnosed until the disease is more progressed because there's no red flag as like a high eye pressure being a catalyst to tell the doctor to start doing some more tests on that patient. As Dr. Williams mentioned, there's a vascular component to normal tension glaucoma. I have severe orthostatic hypotension. So when I stand up, my blood pressure changes and I get like that head rush. And that's common with a lot of normal tension glaucoma patients. I have become a patient advocate because sight is such an important part of people's lives. And it's so important to advocate for yourself. I have my own tonometer, like Dr. Williams was showing the eye care home 2 eye pressures. I have my own tonometer. I take my pressures all the time, so I know what my range of normal pressures are. And at night, before I go to bed, my pressures are 8. So I have super, super low pressure. And I also go often to the glaucoma specialist more than a normal glaucoma patient, just like Dr. Williams mentioned. So I encourage other patients to advocate for themselves and really appreciate being here today. Thanks so much.
Thank you so much for sharing, Hillary. We did receive a lot of questions, so we're going to jump right in. I know you mentioned this earlier in the presentation, but just wanted to reiterate. Is it proven that lowering pressure in normal tension glaucoma patients works to prevent vision loss?
What we know from 2 what we call randomized clinical trials, so it's a very high level of evidence base, is that yes, lowering intraocular pressure slows the progression or stops it, but often just slows the progression of the disease. It's possible, we're humans. So it's possible that there would be a patient who would progress despite really low pressures from what we call non-pressure dependent factors. So it's not just one thing, but in general, yes, lowering the pressure is the mainstay of treatment.
Thank you. What can cause a hemorrhage like the one you showed, and how long can these hemorrhages last?
Yeah, so they last a few weeks. I usually tell my patients about 6 to 8 weeks. What causes them? Oh, that's the best question of all. We don't know exactly, and they don't always signify progression, but they can. I put them in the same category as the Raynaud's and the those other vascular dysregulations, that it's some kind of vascular event or vascular, the fine capillaries there aren't working quite right. They're breaking and bleeding a little bit. Exactly what's causing that, I don't know. When Hillary was talking about her orthostatic hypotension, I actually think that's a very big factor, which is not quite getting enough blood flow up to the optic nerve. And we see that a lot in our low pressure glaucoma patients.
So on that topic, can you discuss Raynaud's and how they're connected to normal tension glaucoma one more time?
Yes. So Raynaud's doesn't cause normal tension glaucoma, but it's more common in normal tension glaucoma. So we don't know exactly, but we think there's an association between that vascular dysregulation. So the fact that, your capillaries, over constrict in your fingers for certain reasons, often because of exposure to cold. And that perhaps a similar process is occurring near your optic nerve. There are some people that theorize there may be some circulating antibodies that cause it, but whatever it is, our vascular systems tend to be more reactive and less stable over time. That's also what causes you to be cold. And migraine headaches too are a vascular dysregulation. So you get this constriction of the vessels in your brain.
Very interesting. Thank you. How are treatment options different for normal tension glaucoma patients as compared to OAG? Ruth, can normal tension glaucoma patients undergo SLT or MIGS? That's the follow-up.
Yeah, so the traditional teaching, before was that, SLT doesn't work so well with low pressures, but a lot of us feel very differently about it, that laser works great. It's just that you have different expectations. So if your pressure is 15 and you do a laser, your goals are going to be to get you down, 2 points or 3, and not the same as a goal if the pressure is high. If your pressure is high, you want to get a lot more bang for it. But when the pressures are low, even 1 point can make a difference. The other thing laser can do is even out those pressure spikes that I talked about. So one of your goals in normal tension is to get the pressures pretty steady and pretty even. But basically, the treatment options for normal tension glaucoma are the exact same as for high pressure, with the one caveat that we might be more prone, as I mentioned, to doing a trabeculectomy just because it works better to get lower pressure. That, by the way, is a big discussion, big treatment decision to do something like that.
Hillary, have you undergone any surgery? And if so, can you tell us a little bit about your experience?
So I have been controlled on drops at this point, and I've done SLT a couple of times, but it didn't really work for me. I would encourage patients to get SLT because if it does work for you, it's amazing. But a lot of normal tension patients, it doesn't work as well for. So fortunately for now, I've been controlled with the drops. And, I mean, obviously in the future, surgery might be necessary for me. But as of this point, my visual field has been stable and I've been controlled just on drops.
On that note, is it possible for intraocular pressure to get too low?
So yes and no. So sometimes we get the pressure too low when we do surgery, sometimes. And that's one of the risks of a trabeculectomy. Trabeculectomy is to get your pressure too low and it causes problems. But no, we're not going to get your pressure too low with lasers or drops or, or with MIGS. We're just not going to get it too low.
Thank you. So someone shared this. When it's close to the time of applying your drops, are you supposed to feel anxiety and depression? Hillary, what is your experience with eye drops? What would you say to a patient who is filled with dread before applying their drops?
First of all, I totally understand. So I think when you first get diagnosed and you start using drops, what a lot of doctors fail to tell you is that these drops are going to have side effects. I think, and there's a reason why they do that, because they don't want to set you up for being unhappy with the drops. But the fact is that you're going to have side effects. No matter what drop you try, they all have side effects. So you might have to play around with the drops and find the ones that you can tolerate the side effects from. So there's several different classes of drugs, and some patients are contraindicated for certain drops, but you find the drop that works for you. Or if you have to be on 2 drops, you find 2 drops that work for you. Maybe there's a combination drop you can take. So it's just 1 drop instead of multiple drops that you're using. If it's a combination drop, being nervous by the drops and having anxiety, like I totally get it. But just know that you're doing it for a reason and that you're doing it to save your sight. And there's always surgical options, and those patients might be a candidate for a MIGS procedure, which could potentially either get them off drops or cut their drops in half. So there's lots of options. And I would say if you're that anxious about it, to definitely ask your doctor for what other options, your treatment options are.
Yeah, I'd add to that. I think anxiety with glaucoma is so common. I have patients who can't sleep the night before they come in because they're scared of what the visual field test is going to show or what their pressure is going to be. So I love, Hillary, your comments about how you understand it and it's normal. And I like to normalize the anxiety. And as I said at the very beginning, information really helps. And the other thing that helps, I think, is looking around and seeing that there are so many other people with glaucoma too who are living, like Hillary, a great life. We can be empowered by all of this, even though it's scary, and it will stay scary. That's okay. We can do things scared.
Thank you. How do we determine an individual's optimal pressure range?
That's a good question. So usually we start out by setting a pressure target. So your glaucoma doctor will set a target for you based on some different things, but partly the severity of the disease, where the scotoma is located, what your baseline pressure is. So each eye can have a different target, and certainly different patients have a different target. But once we achieve the target pressure that we think, based on the evidence, is the right target, then we have to follow the patient very carefully to make sure we've set the target correctly. So once I get a patient where I think, say, I'm making this up, but say I decided a patient needed a pressure of 12 and I get the pressure of 12, but then I have to make sure that they're stable. And that's why I do so many visual fields and so many OCTs on my normal tension patients to make sure.
Thank you. So someone said, I have normal tension glaucoma in one eye. Is that normal? Will it eventually affect my other eye?
Often. Whatever process is causing the glaucoma in one eye, those same processes are affecting the other eye. That being said, some of our patients have these gigantic decade lags between the two eyes. So yes, it's possible just to have it in one eye, but I always watch that other eye really, really carefully. And often the other eye will develop it again later. But sometimes it never develops glaucoma because we're also proactively treating that second eye.
When and if it develops glaucoma, is it the same type?
Typically, although, other things can happen too, but typically that's correct.
So someone asked, should I use a different amount of medication in each eye if the level of glaucoma is different in each?
So we'll very often have different treatment plans for each eye, and it goes back to, how severe is the glaucoma. So if you have mild glaucoma in one eye and a pericentral scotoma in the other eye, I may have a lot more treatment for the severe eye and have a different target pressure for the second eye. So it really is, not only do we personalize medicine to the patient, we personalize the medicine to the eye.
I learned something new today. So our next question is blindness inevitable for all normal tension glaucoma patients? Hillary, can you talk a little bit about your experience with vision loss?
So I would say that, kind of echoing the sentiments of the question about the anxiety and depression that, when you first get diagnosed with glaucoma, and at first I didn't understand the severity and what that meant. And then once you kind of process that, which took me about a year to really process it and understand what was happening. So it takes a while for you to really understand what's happening, and the visual loss is frightening, because what happens is our brain is really smart, and it actually, our data overlaps because we have two eyes. So the brain kind of interpolates data or fills in information that's missing, which is amazing. So most of my visual loss is by my nose in the upper nasal quadrant. So because we have two eyes, my eyes are able to compensate for each other and that vision that's lost. Sometimes I do notice it. Sometimes I'll see, you look at someone and they don't have a head because they're in that part of your vision where I can't see that upper part, and like I can't see my hand right now. So there's parts that you just can't see that are missing. So it's very scary. But what I'll say is not the percentage of patients that go blind from glaucoma is very small, especially if you're being treated. So that's why with normal tension glaucoma, you're being monitored so closely, because if there's any changes in the visual field, then that treatment plan might change. And that's going to be something that you need to discuss with your doctor. Are you going to add a drop? Are you going to do a surgery? Or are you going to do a minor surgery, like a less invasive surgery, like a MIGS? Or are you going to do a tube or a trab, something that's more invasive? So those are all options that you have in order to try to save your sight. So we have lots of options and lots of treatments that we can choose to do. And I think, again, empowering patients is key, and you just have to ask lots of questions and make sure you understand what your treatment options are. But you will not, it is not a given that you go blind when you have glaucoma. And, that's what I initially thought. And so there's hope with this disease, as long as you are using your treatment and doing what you need to do and making your appointments and going to your appointments and working with your doctor, the chances you're going to go blind are very, very slim.
Thank you. Another question for Hillary. How does normal tension glaucoma affect your daily life? What kind of low vision strategies do you recommend?
So as far as daily life, I'm on drops in the morning and at night. So I use my drops, I use my tonometer. And other than that, because I'm so invested in researching glaucoma and in helping other patients, it's a big part of my life. But as far as, accepting glaucoma, I think I've accepted that I have it. And I think that is part of, everything I do every day. Low vision, there's not anything that I need right now for low vision, even though I've lost so much of my visual field, because it hasn't crossed over to that central vision area, which is when you really notice when you can't fit things together, because there's missing parts on both sides of central vision. So I haven't needed the low vision resources. There are a ton of low vision resources out there. There are so many different apps, so many different tools. And I don't know if Dr. Williams knows a better answer than me as far as that goes, but I know in some areas it is very difficult to find low vision resources and people that work with patients, but other areas have great resources. So I think it depends on where you live, but I think that no matter what, you can find resources online.
I'll make one comment about low vision. We actually have a low vision center in our parking lot in a house next door. So I refer patients very early, and I'm not waiting till people have severe vision loss to send them over, because often there are little practical things that you can find help with. So yes, we do have a shortage of low vision services, but those centers are so full of hope and help and psychological support too. So yes, I agree with everything Hillary said. Low vision services are great. I would make one more comment about being blind. What does being blind mean? Most people think of losing everything, and yes, that rarely happens, but I don't even like to use that word because it means different things to different people. What I like to call it is vision loss or low vision, because that's very specific to you and what your experience is. So you can have 20/20 vision and have profound vision loss because your blind spots, Hillary, your description of your blind spots is amazing. So, you probably have perfect, I don't know, but you probably have perfect vision, and yet you've got these holes in your vision that can be very impactful sometimes.
Thank you both. Is normal tension glaucoma hereditary? Will I have glaucoma if one of my parents did?
So anytime you have a family history of glaucoma, it increases your risk of glaucoma. And I'll give you an example. Families with, those thin corneas I talked about, that tends to run in families, and that increases your risk. But just because you have a parent or even two parents with glaucoma Doesn't mean you'll get high pressure or low pressure glaucoma. It just increases your risk. So anybody with a family member with glaucoma should get a exam. And one of the most important, those of you on the call with glaucoma, the most important thing you can do for your family members is make sure they get checked. The other thing is that siblings with glaucoma actually are the ones that confer the highest risk of you getting it. So if your sister or brother has glaucoma, that's an increased risk for you.
That's the same for all types of glaucoma, or does it differ?
Yes, yeah. So what's really interesting about glaucoma is it's not one disease, it's many diseases that have something in common. And what they have in common is the kind of optic nerve damage that develops. And so, yes, it's hard to answer that question because there are dozens of kinds of glaucoma.
What's your opinion on home IOP monitoring? How accurate or helpful is it? Ruth, do you mind?
Home IOP monitoring is challenging for a lot of our patients because it's not yet reimbursed. I'm hoping that changes in the future, but insurance or Medicare doesn't reimburse for it, so the patients have to pay for it. Or in Hillary's case, I think you might have bought yours, and they're expensive. So it's a great tool. I love it. There are times when it helps me decide whether I need surgery or not. But until we get a reimbursement model for it, it's not something that's going to be available for everyone. But I do really like the data. And even if the actual numbers aren't perfect, getting that range, or as I showed you in my talk, finding out that somebody spikes at 4 a.m. Intermittently is super, super important. And in a sense, I don't care whether the pressure is 17 or 21. The fact is it's spiking up and I need to get that down. So yes, it can be very helpful.
Hillary, I know you mentioned you use one. Do you have any recommendations for patients who are interested in getting one for themselves?
I mean, I can't recommend the eye care home 2 tonometer any more highly. It is a phenomenal, guide to help with treatment. So, as I was kind of explaining earlier about just using new drops or getting off a drop, it helps you to know which drops work best for you, and it helps you, like Dr. Williams said, at night if you're I was waking up in the middle of the night and I was like, oh, I'm already awake, I might as well test my eye pressure. And so it enables you to test your eye pressure at times where you couldn't go to the office to get it tested. The other thing is, once I got a range of pressures of my eye, I realized the way that glaucoma has been treated for years is by testing eye pressure once every 3 to 6 months is just crazy. Because if you see your eye pressure across the plot and the diurnal curve, which is the curve that your eye takes throughout the day, because your eye pressure does go up and down, it doesn't stay stable the whole day. So there's just a natural curve to your eye pressure, and seeing that, it's just eye-opening, because you realize that, getting your eye pressure tested once every 3 to 6 months is insufficient for treating glaucoma. And again, this is how glaucoma has been treated for years and years. But going forward, we have new tools. So I think that, home tonometry being one of them is amazing. And like Dr. Williams said, it's, it can be cost prohibitive because not all patients can afford it. But even if you can rent a tonometer for a couple weeks and just get your baseline of your diurnal curve, then you kind of have an idea of what your pressure is on an average pressure is on a daily basis, to kind of learn a little bit about that. And then you can use that graph to show your glaucoma specialist, and they can maybe adjust meds or make recommendations based on that. A lot of times when I take my pressure, if I find that it's high at one point, I'm on 2 different drops. One of those drops can be taken up to 3 times a day, and I don't use it 3 times a day. But if my pressure is higher, I could add an extra drop that day. I also have Diamox or acetazolamide, and I could take acetazolamide if my pressure is higher. So it enables you to do some things that to get your pressure down that you just are aware of, that you wouldn't have been aware of without the tonometer.
Thank you for that. What types of exercises are safe for normal tension glaucoma patients? Can they lift weights?
Oh, well, that's a great question. So, anything like, Valsalva type maneuvers. So playing a trumpet, lifting weights, doing resistance exercises, those kinds of things do temporarily raise intraocular pressure. The question is how much and for how long. So typically I tell my patients, as long as we have your pressure well controlled and you're doing fine, go do all those things. Go live life. I'm going to watch you and make sure you're doing okay. If you have, a scotoma near the center and severe glaucoma, and I'm worried about, little periodic pressure spikes, then we might have a conversation about those things. But most of my patients, fine, go do it. Because, after all, our point is quality of life, not what your pressure is every single minute. But that being said, one thing that raises pressure too is to invert. So, hang from your feet upside down. I don't want you guys doing that for half an hour. So, but the rest of it, yeah, go do it and live. And if your glaucoma is getting worse, we might look at it more carefully. But for the most part, playing the trumpet's not going to hurt you, or lifting weights isn't going to hurt you most of the time.
Hillary,
and let me say another thing. As you age, resistance and weight bearing exercises are actually more important than cardio, because you want to protect your skeleton. And so you're weighing different risks. You don't want to, fall and break your hip. So I'm a big fan of weightlifting, especially as people age.
do you lift?
I do. I think it's really important.
That's awesome. Hillary, what changes have you made in terms of your diet or exercise regime since your glaucoma diagnosis?
So everything Dr. Williams said, I totally agree with. Like you can't be totally consumed by the glaucoma and your eye pressure all the time. Like once you kind of have an idea of everything, you have to have some, you have to be able to live life and enjoy life. So for me, the one thing I don't do is I don't ever put my head below my heart. So I don't do the bending over, like the Valsalva maneuvers that Dr. Williams was talking about. I used to do a lot of planks and yoga poses, downward dog, things like that. I don't do that anymore. That said, I still am able to exercise. I do lift weights. I don't lift super heavy weights. So anything that kind of where I feel the pressure in my face kind of building up, if the weight's that heavy, then I'll usually go a little bit lower than that. So that's just for me. Everybody's different. So everybody has to find what they're comfortable with. But I do that. I eat healthy. So I was actually diagnosed with breast cancer in 2010. And then after that, I started learning more about food, and I changed the way I ate at that point. So by the time I was diagnosed with glaucoma 10 years later, I had kind of changed my diet and been a lot more conscious of what I was eating. And so I eat on the healthy side. Now, healthy means something different to everybody, but I definitely try to get colorful fruits and vegetables and protein in my diet. Everybody's going to have, different parameters of what they like. But as far as exercise, health and exercise, I think it's so important, like Dr. Williams said, to look at your whole health, because it's not just about your eyes. You have to maintain your skeleton, your everything. And so it's important not to just get too overwhelmed with the glaucoma piece of it, and make sure you're taking care of your whole self.
I can't believe, Hillary, you just had this conversation. We did not cue this up together.
No, we didn't.
We plan ahead. I actually think diet's hugely important for our nerve health and for the rest of our health. And I think we should be talking about diet today in the same ways we were talking about smoking in the 70s. My patients say, what can I do what can I do in my day-to-day life to help stop my glaucoma? And I always say, well, you're already doing one thing, which is you're not smoking. So don't smoke. And the second thing is to do exactly what Hillary just said, healthy diet, which I think is non-processed foods, minimize processed foods and as many fruits and vegetables as possible. And, I even advocate for a plant-based diet, but not everybody wants to do that. But those are the things that are going to make your vascular system healthy. And we've already talked about how vascular dysregulation is a risk factor for normal tension glaucoma, as is diabetes and hypertension. So all of those things are impacted by a healthy diet. It's hard to do. And so I talk to my patients about this all the time, which is let's make incremental changes in your diet. And it might just start out by fixing 2 vegetables for dinner instead of 1. That's how I started. Mostly because I thought the more vegetables I had on the table, the more likely my kids would eat one of them.
Did it work?
Yeah, actually, all 3 of my kids are all grown up, but they're all good eaters. Yeah, they're all super healthy eaters. In fact, they're more neurotic than I am about it.
That's awesome. So our last question, Hillary, have you faced any negative repercussions to being a glaucoma patient advocate? For example, job discrimination, problems getting your driver's license renewed, or insurance discrimination? We'd love to know a little bit about that.
So I personally have not, had run into any discrimination as far as my glaucoma. I'm currently working for myself, so I don't discriminate against myself for sure. But I am the only place where it can be a little tough with glaucoma is sometimes chatting with other glaucoma patients, because everybody has their own ideas of things. And so I think it's, as a patient advocate, it's really important to give the patient space to really say how they're feeling and how the glaucoma is affecting them personally, because everybody has their own journey. It's not just about, how it's affecting me. It could affect me totally different than somebody else. So I think that, anything's possible, but I try to look at the positive side of things and say that, we talked about, these missing pieces of vision, right? And I try to focus on the pieces I have left, and I focus on what's there, and I focus on what I can do with the vision that I have and how I can move forward with that. If I wanted to focus on the vision that I lost and, woe is me, I could definitely have a pity party. And every once in a while, I have days where I'm just going to be sad today. And I think that's okay, because everybody has to go through that. But I think that, you have to pull yourself out of that and keep walking. And if it takes baby steps, first you do baby steps, and then you take bigger steps, and you find ways to really focus on the sight you have and make a difference that way. And that's what I found has worked for me. But again, everybody's different. But I think that it's really important to find the good in your diagnosis and find out, okay, what can I do with this? This is the diagnosis I have. How can I deal with this? And the way I've dealt with this by helping other people.
Thank you both.
Thank you, Brizette.
Thank you, Brizette. Thank you, Dr. Williams.
It was a pleasure having you. Thanks so much for making time to be with us today and for providing such insightful information to our glaucoma patients, family members, and friends. And thank you to our attendees for your interest and support. If your question wasn't answered during today's webinar, please visit our website at glaucoma.org for more information. You can also email us at question@glaucoma.org. And please don't forget to mark your calendars for June 28th and 29th for our 6th annual Glaucoma Patient Summit in Philadelphia. You can go to glaucoma.org/summit for more information. Thank you once again for being with us here today and for joining us in our bold vision of a future free from glaucoma. Because of your continued partnership, the cure is truly in sight.